Anybody who has ever seen a commercial for cholesterol-lowering drugs, or statins, understands that they are big business. But statins also have a widely accepted place in modern medicine for treating patients at high risk for heart attacks or strokes. So while it makes sense to be somewhat skeptical about the sales pitch you hear on a commercial for a statin drug, many people nevertheless believe that the benefits that these drugs provide in terms of reducing risk of cardiovascular disease is worth dealing with potential side effects. Recently, however, researchers have begun to recommend that people at a lower risk for heart disease should also take statins. Previous guidelines have suggested that statins have the greatest benefit for people with a 20% risk of a heart attack or stroke over the next 10 years. New recommendations would include people with only 10% risk, a move that could greatly expand the number of people eligible for statin prescriptions. Not everyone thinks this is a good idea. The controversy surrounding cholesterol levels and their relationships to heart disease has a long history, stretching back to the 1950s. However, the newest chapter in this debate began with a review of data from a number of statin drug trials that suggested that statins would be beneficial for people at low risk of heart disease. An article by Dr. John Abramson and colleagues published in the British Medical Journal, or BMJ, disagreed. Abramson and his co-authors reanalyzed the same data and came up with a different result. Their result indicated that the risk of side effects from statin use for this particular group of people outweighed any potential benefits from reduced risk of disease. Their article stated, "The evidence does not show that the benefits of statins in low-risk patients outweighs the harms. Thus, the advice for treatment of this group should not be changed." The data the paper analyzed were originally from the Cholesterol Treatment Trialists Collaboration, a research entity established at the University of Oxford in 1994 to investigate the risks and benefits of statins. The group is headed by Dr. Rory Collins. Collins was outraged by the Abramson paper and immediately expressed his concerns to the editor of the BMJ, eventually demanding that the paper be retracted. As a classic risk versus benefit controversy, what's at stake depends on which side you're on. For those arguing for the benefits of expanded statin use, more people could die if they took Abramson's advice and decided not to take statins. Those on the other side of the debate, however, argue that the risks outweigh the benefits. If statins are not needed, they can reduce the quality of life through side effects and turn nearly every adult over 50 into a patient, even if they have no sign of disease. In addition, with statin sales in the billions, prescribing them for more people could directly benefit the pharmaceutical industry. The guidelines that doctors are given regarding statin use affects their level of liability when they do or do not prescribe statins to their low-risk patients. Finally, the scientists involved, particularly those whose research is supported by statin manufacturers, risk losing funding and prestige if their research is shown to be flawed. As with most scientific controversies, principal actors on both sides of the issue are deeply invested in their positions. The first author of the article that sparked the controversy, John Abramson, is a lecturer at Harvard Medical School and a physician who has practiced family medicine for 20 years. He's also an expert witness in litigation involving the pharmaceutical industry and the author of the book Overdosed America: The Broken Promise of American Medicine. His antipathy for expansive use of medications is no secret. On the other side of the issue is Dr. Rory Collins, co-director of Oxford's Clinical Trial Service Unit, the research organization that runs the Cholesterol Treatment Trialists Collaboration. It is essentially his data to which Dr. Abramson has raised objections. He is a highly respected researcher, author of hundreds of journal articles, who is knighted for his services to science. His research unit also receives millions of dollars in funding from statin manufacturers. Although the BMJ is mainly read by clinicians, the controversy became of widespread concern as scientists argued over the implications of the Abramson paper. Should low-risk patients be prescribed statins or not? As Dr. Collins called for a retraction of the Abramson paper, the BMJ felt it was necessary to form an independent statins review panel to determine the outcome of the situation. In the meantime, scientists and researchers with ties to the pharmaceutical industry weighed in vocally to support Dr. Collins's call for a retraction. The BMJ is a prestigious online scientific journal with a reputation for challenging the medical establishment. Ostensibly an authoritative and objective organization, the BMJ has also been a strong advocate for more transparent research practices and against the overuse of medications. Their online format and rapid response letters to the editors section allow for vigorous online discussions on controversial issues. In this particular debate, the editors of the BMJ corresponded regularly with Collins and Abramson and posted all their correspondence for BMJ subscribers to view, even letters that Collins stated were not for publication. The mass media picked up the story, and both Collins and Abramson offered their opinions in interviews, quotes, and editorials. How each of the principal players framed the issue at hand is central to the narrative they create surrounding risks and benefits. Collins focused on a small section of the paper dealing with the side effects related to statin use, which Abramson and his co-authors had overestimated and erroneously suggested were caused by statins rather than simply associated with their use. Collins accused the authors of deliberate and repeated misrepresentations of the side effects of statins. Parts of Collins' argument were valid, and Abramson published a correction, although whether or not Abramson's mistake was deliberate is a different matter. Abramson, on the other hand, redirected the issue to the fact that his analysis showed no benefit for people at low risk, a fact which Collins appeared not to contest. So why should they be exposed to any risk, even if it was lower than what the article originally stated? Arguers on both sides of the issue used various means of persuasion to make their cases. Despite it being an argument over data interpretation, which would primarily involve an examination of the evidence and would focus on logos, most of the arguments used centered on emotion, particularly fear, and credibility, so that pathos and ethos played prominent roles in the debate. Both parties made appeals to pathos, using fear-based arguments to make their cases. Collins made the argument that Abramson's article was hazardous to the public's health and could potentially lead to large numbers of unnecessary heart attacks, strokes, and premature deaths. He argued that Abramson's article was even more dangerous than the one by Sir Andrew Wakefield, which supposedly demonstrated how vaccines caused autism, and which was eventually retracted. Collins argued that if Abramson's article was not retracted, lives would be at risk. Similar arguments were raised by Abramson, who also appealed to the fear of increased unnecessary side effects and decreased quality of life. Abramson argued that statins discouraged patients from undertaking lifestyle changes like diet and exercise that were more beneficial to their health without the harmful side effects. Both sides accused the other side of fear-mongering. Regarding ethos, both sides questioned the other's motives, implying that financial gain was at stake. Collins accused Abramson of making money from litigation and his book sales. Abramson accused Collins of having financial ties to the pharmaceutical industry and went on to suggest that Collins' findings were influenced by this relationship. Concerns about industry's influence on science are not new, but this line of argumentation put Collins on the defensive and expanded the debate to a wider circle of interest. Collins defended his credibility by asserting that he did not accept money from drug companies. Malcolm Kendrick, a physician and vocal critic of statins, entered the fray, pointing out that Collins' research unit, on which his entire career is based, is primarily funded by pharmaceutical companies. One of the most influential trials led by Collins, involving 30,000 patients from all over the world, received about $150 million from statin manufacturer Merck, Sharp, and Doe. The arguments of credibility became personal, as Collins questioned Abramson's competence, pointing out that his contribution to the medical literature amounted to 9 articles in the past 10 years, consisting almost entirely of commentaries and letters on other people's work, rather than original research. Abramson's own version of an ad hominem criticism was to point out Collins's use of them, and appearing to rise above such arguments, pointing out that such attacks did not contribute to the debate at hand. Both parties ultimately did turn to empirical evidence to make their arguments, although the underlying issue is still very much about credibility. Collins asserts that the results of his studies speak for themselves and are not influenced by funding. Abramson uses the results of other studies to argue that investigations funded by industry are much more likely to favor the use of a new drug than those without industry funding. Collins stands by the empirical evidence collected from 100,000 participants that shows that statins have few side effects. Abramson counters that if the data is that strong, Collins should have no issue with letting other researchers see it. Not to do so, according to Abramson, is cause for suspicion. While both arguments appeal to empirical evidence, whether or not to grant this evidence authority depends on which side of the debate you are on. Is Collins' data really valid, or does it only appear valid to those inclined, perhaps by industry influence, to see it that way? To a large extent, Collins' argumentation reflects a defense of the status quo or orthodoxy to which Abramson's article was a challenge. He had insisted on public correction, he had ridiculed Abramson's contributions to research, and questioned Abramson's competence and motives, although Abramson had questioned Collins' motives as well. Other responses to challenges to the orthodoxy are boundary work, ending the debate by either getting rid of the person doing the challenging or by simply declaring the debate to be over, and forum control, which is a means of controlling communication by deciding who gets to participate in influential discussions. We see examples of both of these strategies in this debate, with an interesting twist. One way to end challenges to the orthodoxy and to maintain its boundaries is simply to assert that there is no debate. The science is settled, a fact is a fact. Collins does this. The BMJ responds, however, that in their view the science is not settled, and that the matter at hand should be subject to debate and question. Collins, not satisfied with Abramson's published corrections, asked the BMJ not only to retract the entire paper, but prevent Abramson and his co-authors from ever being published in BMJ again. In other words, he would like to drive the heretical article and the heretics out of the academic conversation altogether. On the other hand, the BMJ, although somewhat unorthodox in their own views in some respects, takes the position of the orthodoxy in this part of the debate by controlling the forum in which the decision about retracting the article is made. The editor of the BMJ decided that the debate will be resolved by an independent panel, the chair of which is a scientist, Iona Heath, who has been a vocal critic of statins in the past. Collins did object to this leadership of the panel, but because in this case he is the outsider challenging an institution, Heath remained as chair of the panel. In the end, both Collins and the BMJ make their final arguments based on an appeal to a higher authority, in this case COPE, or the Committee on Publication Ethics. Collins argues that if the panel looks at COPE guidelines, they will see that the Abramson paper should be retracted. The panel agrees that COPE guidelines are the final authority, but they find that the guidelines indicate that the paper should not be retracted, and that is more or less the end of that particular matter. It is not, however, the end of the controversy. In August of this year, the BMJ's Independent Statin Review Panel made public its decision not to retract the Abramson article and also made public all the materials involved in the debate. But just a month earlier, Britain's National Institute of Health and Care Excellence, their version of the NIH, issued guidelines recommending that physicians prescribe statins to patients who are only at low risk of heart disease, exactly the situation that the Abramson paper argues against. It seems likely that there will be future challenges to this orthodoxy, and that the controversy surrounding those challenges will involve rhetoric as much as science.